So, good afternoon, everyone. Thanks for coming. We've had the introduction with Dan already, so I won't go into that. But I'm Sarah Jane Tribble. I'm the moderator for today's panel. I'm a healthcare reporter and producer over at IdeaStream, WCPN, WVIZ. Before that, I've been a healthcare reporter for years at the Plain Dealer previously and in print journalism previous to that. Today, we have the honor of talking about chief experience officers and the patient experience and how that has shifted in recent years. In today's world, the patients have become consumers, whether we like it or not, whether that's how we want to view them or not. They have high deductible health plans. They're shopping around more in order to use those plans. In Cleveland, they have a myriad of wonderful doctors and hospitals to pick from, so they're shopping around with that. And even the government has joined the shopping game, putting out surveys to patients and to hospitals to test how well people are doing, and then now reimbursing based off those surveys, the HCAP surveys, which we'll talk a little bit more about later. So what does it take to keep a patient satisfied? I'm sure it's a question a lot of you guys ask yourselves if you're in the industry, and if you are the patient, you probably ask yourself that after you leave the hospital or after you leave your doctor's appointment. The solution for many in the industry has been to create the chief experience officers. A recent research report noted that there are now more than 50 chief experience officers in the healthcare systems across the country. Plus, there are hundreds more that aren't in the C-level suites. So this is a growing phenomenon. I'm going to go to the part that I always mess up on, so please forgive me. The names in the healthcare industry have wonderful titles to them, so please be patient as I introduce our wonderful panelists who have been in this field for a number of years, and I'm looking forward to learning from them. We have Dr. Adrienne Boissy. She's a Chief Experience Officer at the Cleveland Clinic. We have Koppelman. She's a Chief Nursing and Patient Experience Officer at University Hospitals. We have Sara Laskey. She's the Chief Patient Experience Officer at MetroHealth. And that's Dr. Sara Laskey, sorry. And Sue Tyler, Executive Vice President and Chief Experience Officer at Medical Mutual. Thanks for joining us, you guys.
Thank you.
We were having... So I thought we could start off by talking about what exactly the Chief Experience Officer is and this shift that we've seen in recent years. And to use a phrase that we were talking about earlier, previous to coming up on stage, this idea that whereas before we expected the caregivers and the doctors and the nurses to just care for the patients, now there's a shift, a cultural shift where we want to teach them more. So if each of you could talk a little bit about your roles and then kind of talk a little bit about how you see that shift taking place, just to get us started and to introduce yourselves, I'd really appreciate it.
Well, you're
Adrienne?
looking right at me.
Yeah.
So I really view my role as a couple things. So I am a normal neurologist by background, so I'm committed to just providing excellent clinical care for my patients. But in my hat as CXO, I view my role as part inspiration and part execution, meaning I have a lot of passion around patient experience. I hope that every caregiver has a lot of passion around patient experience, and I believe that they do. And at the same time, we need to be able to deliver programs that have meaning for people as well as for our patients, and be innovative in their design and implementation and make sure they sustain. And to me, that requires a lot of creativity and on-the-ground wherewithal. The other thing I would say is you mentioned shift. So in my role, I think part of my job is to define patient experience. Patient experience isn't this soft, fluffy thing. It's safe care, high quality care in the context of patient satisfaction and high value. We need to be crystal clear about our definition of it. And lastly, the shift piece, we used to be doctor-centric, and now we've swung patient-centric. And I'm very interested in driving an agenda that's relationship-centric, meaning both people bring value to the table. This is an emotional business. We have reciprocal influence on each other, and relationships in healthcare can in fact be therapeutic.
Okay, thank you. Kathy, I know that when we were talking earlier, that for a couple of folks, the term consumer was bothersome. If you could kind of talk about what your role is and the shift.
Well, I have been a nurse for about 44 years, and the patient and the family has always been central to the practice of nursing. And in my executive role, I have always focused on patient experience with nurses in interdisciplinary teams. And my role expanded to really look at the whole continuum of care, to be the leader responsible for bringing together the vision and the plan and the clinicians and the staff around improving, continuing to nurture a culture of patient experience. And your point about consumerism, I think, is really very important. I think that it's most important when you look at things like access to health care, ease of scheduling, waiting times. Those types of things, I think, are very comparable to consumerism. I think where I react to that is it does not take into account that a consumer's independent, they are out there shopping, they're making a decision to purchase something. When someone comes to a healthcare system, they're coming because they have a problem with their health. And with that, it has a whole different dimension in terms of the vulnerability that one has, the needs that one has, not just physically, but emotionally. And it's really important to be able to connect therapeutically to others, but to feel safe, to feel a trusting relationship with particularly your clinical staff, your physicians, but anyone who comes into contact with you. You have to have this, there is a need and we need to meet that person's there for you, they're advocating for you, your needs come first.
Great. Sarah, if you could introduce yourself, your goals and your job.
Absolutely. You talk about a cultural shift, and I think that applies to both what is happening in this industry and why these jobs exist. And for myself, there was a cultural shift at Metro 2 years ago, which allowed me to take on this position. The cultural shift that occurred around 2008, 2009, I think happened because of the triple aim from the Institute of Healthcare Improvement. When they started to say, what's happening with population health, what's happening with patient experience or patient satisfaction, and how are we spending our money around patients? Around the same time, the government got into all of this and said, oh yeah, we are the biggest payers of healthcare, essentially, and we want to know what's happening with the experience of the people that we're paying for, because it fits in, as Adrienne said, with quality and safety and outcomes and other metrics that we care about. So that's a big cultural shift in how we look at what's happening and how we're looking at the patient and their experience. So I think that's the cultural shift that the country and hospitals and healthcare systems have gone through. For us at Metro, we had a tsunami whose name is Dr. Akram Boutros. He came in and really made a cultural shift in that he allowed us to start to look at what we do and our mission in a very different way. And he let a little short emergency medicine doctor, me, say, I think we need to do something about our patient experience, and I think we need to start looking at all the aspects and all the touch points of care, and not just our mission, but all of those pieces. And he said, go for it, build a department, let's start making a difference.
Okay. Sue, you're the odd panelist out here. You're with the insurance industry.
I know how I feel about the odd part, but the rest of it's true.
I think when people think about chief experience officers, it's easy to think in a hospital, you're caring for patients and the experiences of the patients that we're focusing on. When it comes to members, it's a little bit different. So how do you kind of tackle this position?
It is a little bit different, but understand that when our members have encounters with us, they frequently are patients in the healthcare system. So I think there is a lot of synergy between what you do and what we do at Medical Mutual. I have functional operating responsibility for several of the departments within the company, administrative and operationally, but we realigned and I adopted the Chief Experience Officer title back in 2009. And we recognized we needed to make a transformation from viewing what we did as tasks or individual functions to be completed, and we needed to put the member, in our case, or customer in the center of that, and flip things around and try and view what we were doing, not from an internal perspective, not just from a transactional metrics, but how does this impact the customer? And it really, you both mentioned culture. It is a cultural shift, and I view a lot of my role as making sure that our organization understands the strategic importance of the customer experience to our business, raising awareness, engaging employees, and really, since we don't see many of our customers, is making sure that our customers' presence is felt in our meetings, and when we're making decisions that we say, how is this going to impact our customer? How are we going to communicate this to our customer? Is really just kind of raising that awareness across the company, whether it's with people that work in the legal department, the accounting department, the mailroom, that what they do is part of the customer experience.
It's interesting. I want to come back to that kind of in administrative meetings and the cultural shift. But before we move away from kind of the medical mutual, the insurance industry aspect of it, you said 2009, which is before the Affordable Care Act passed in 2010. Many of the kind of financial reimbursement things have come since then. The Affordable Care Act has put out the individual health insurance exchanges. How has that impacted the way that you approach patient experience for your members?
We did this for a lot of reasons. Again, it was before the Affordable Care Act, but certainly the individuals buying their own coverage and becoming customers of health insurance has increased in the marketplace, so that was a factor. All of our members, whether they're individual customers or part of a group or an employer-based plan, are seeing higher financial personal liability for their health care. So, their needs have changed and evolved over time. Technology, the transparency around what is happening with services, you can read a review, you can shop online, you can tweet your experience, whether it's good or bad, and with the push of a button, share it with thousands of people. There were a lot of reasons we did this, but you go back to, we don't sell a tangible product. We sell peace of mind. And so our reputation is everything. So our customer experience is critical to us, keeping the customers that we have, attracting new customers, and hopefully having our current customers recommend us to others in the marketplace.
Right.
So it's strategic for us.
Okay. When we had talked about this previously, Kathy, you pointed out that at UH, you took over the position in 2013. Tom Zenti appointed you. And since then, what you've seen is throughout the departments, every meeting has a patient kind of experience aspect to that. Can you talk a little bit about how that plays out on a daily basis?
Mm-hmm. I'd be glad to. First of all, I think that the point in what you're raising is, and it's been already talked about, is that this is about culture. It's not about teaching people to practice scripts in talking to others with patients and so forth. It's genuine, normative values, beliefs. And culture starts with leadership. And so what the leaders do and invest their time in is what the employees, the clinicians, know is important. So we have encouraged a number of different ways in which to enhance our already caring culture. One of those is that every administrative management meeting, including those with staff, begins with some aspect of patient experience, because it's that important. It grounds everyone in, this is our purpose, this is why we're here every day. So that can take the shape of reading a letter that came from a patient, a grateful patient, telling a story from a patient's perspective, as the patient told you, because all of our leaders round in our clinical environments and sit and talk with patients and families. But in many of them, we actually bring the patient in, and the patient speaks to the leaders. Tom Zenti has a quarterly leadership meeting with 1,000 leaders, and we have a patient come in. That's how we always begin, and that patient tells their story. We do retreats with patients and families. We bring them in, we have them tell their story. The power of storytelling is what reinforces the culture. It's the story you remember, the story of what a difference we made in this patient's life, or what we didn't do to meet their needs, and how can we learn from that.
And this didn't happen 5 years ago.
No, it did not.
And when did you start bringing patients into kind of the daily meetings?
We started bringing patients into the retreats about 4 years ago. Then we started bringing them into, it's can be very scary for a patient to get up in front of a whole group, so you really have to provide the support and the assistance to do that.
It's interesting that you mentioned the practicing scripts, and I'm going to use that to kind of segue over to Adrienne real quick. And this idea, last month at the National ACO Summit in DC, your executive, Dr. Cosgrove, was speaking very proudly about how the hospital has changed its HCAP scores, which I'm going to read the official title of that, Hospital Consumer Assessment of Healthcare Providers and Systems Patient Experience Scores. You guys have improved those drastically in recent years. However, then he started lamenting the fact that the biggest complaint was that the doctors did not know how to talk to their patients, right? Do I have that correct?
You're the report. I can't confirm or deny.
He has lamented that in the past. The lack of doctor communication remains the most common patient complaint. And that led to implementing mandatory communication classes. So is there a script that you do kind of forward out to your staff members, your caregivers?
Yeah.
Is that important?
So a couple things. So first of all, communication in healthcare is not a Cleveland Clinic problem.
Right.
It's a national epidemic. Let's be crystal clear. Communication in healthcare is a national epidemic, period. And so I think as I go around the country, I'm sure as my colleagues go around the country and in their own environments, we are all trying to figure that out. The second thing is that, just factual, that we developed a program that really was meant to meet the complexity of healthcare today. And our clinicians evolved it, and we trained 1,000 physicians voluntarily. And it was only after demonstrating improvement that we decided to take it across the healthcare system and actually integrated it into our onboarding, into our leadership development, into advanced curriculum. And the last piece of that is, if you really think about communication in healthcare, I mean, when I was asked to evolve a communication curriculum for the Cleveland Clinic, I thought, oh, that'll be great. Training experienced clinicians who think they know how to communicate very effectively in communication skills, who have been practicing for 30 years. That'll be awesome. And, but then as I actually sat down and thought about it, medical care is complex. It's more complex now than it's ever been, right? Patient expectations are high. The demands on our caregivers are very high. We have less time to communicate effectively. In fact, if you ask clinicians, the biggest dissatisfier in their practice is that we're pulling them away from the very patients they want to serve by all these, I call it the assault of checkboxes and requirements. And so we thought a lot about creating a program that wouldn't just give people skills, right? Or give them a script and tell them how to do it, because you're dealing with intelligent people. The intelligent people don't recite scripts.
Right.
They remain empathically curious about what's going on with the human in front of them. They have a self-awareness to be able to know what that patient may need to hear. They have an interest in understanding the fears and worries and expectations that are unspoken. And that's the type of clinician we wanted to make an investment in. Those are the skills we wanted to evolve in our caregivers. And that became very interesting to me. And so the program that we ultimately evolved demonstrated, really worked with them in a way to sort of say, tell me what your biggest challenges are in practice, and let's talk about that as a group and leverage the group expertise in the realities of your world to come up with some solutions and language, and let's play with that and see what fits for you in your practice. And clinicians are hungry for that, right? It's not just another program or initiative. You're not just giving them skills. In my mind, you're really nudging their very thinking about what makes this work so meaningful to them. And when you're able to do that, that is transformative work.
And I should note that actually the Cleveland Clinic has been a leader in patient experience. You had one of the first chief experience officers in the country a number of years ago, and you are the third one at the clinic. So this isn't...
I'm sorry, are you saying they came before me?
This is nothing new for you. But I do think one of the confusing things for kind of the average person is this idea that doctors and nurses need to be taught how to care, right? Because that's what they do. So, Sarah, if I could kind of look to you kind of to explain this difference. And I know we're talking about the cultural shift, and it makes sense that you'd want to have meetings and introduce the patients on a regular basis, especially in such a busy environment. But as a patient, the doctors are caregivers. So that's kind of what they do. So why do we have to address this again in a different way?
I don't think doctors and nurses have to be taught how to care for patients. I think that we need to work on creating an empathetic connection, which is a very different skill. Particularly, I think nurses oftentimes get more training in this, although I didn't go to nursing school, so Kathy may be able to answer this better. But in medical school, we don't spend a lot of time on the empathetic connection. We spend time on diagnostics, we spend time on clinical acumen, on procedural skill. But when you get into a room with a patient, it is a one-on-one connection. And what we've learned is that all of the clinical outcomes and all of the things that we want to happen because of that clinical interaction are dependent on the communication that happens. So whether or not they follow your discharge instructions, whether or not they're going to come back for the right appointment, whether or not a patient actually gets why you're doing what you're doing, if that connection doesn't happen appropriately, then all the things that fall out after that aren't going to happen. But you can't just sort of, as Adrienne was saying, you can't really just sort of tell somebody, go do this. It's a skill. It needs to be taught just like everything else. And it's a skill that I think we use not just with our patients, but we use with our colleagues. We use in all of the different interactions that we have within the healthcare environment and within our personal environment. And that just makes for a better experience along the way. Teaching our physicians, teaching our nurses how to do this is important, but I think it's also important that every single person that you interact with in the hospital setting has that ability. That's part of the message that we're trying to give in our organizations, is that it's not just that one interaction. It's every single interaction that's going to impact how that patient feels about their experience. And so all of them are important, everyone is important, and we have to sort of teach that skill at some level to everyone.
Okay. The federal government, I've mentioned it, has the HCAP scores, a measurement where they survey patients in the hospitals and so forth. Kathy, I'm going to look to you real quick because at university hospitals, you were the chief nursing officer before that. You were dealing with kind of patient satisfaction scores previously. Can you talk a little bit about HCAPs and what that has meant to the hospital industry, specifically around chief experience officers?
Well, there are a number of different surveys depending on the patient population and what level of the continuum they're on. So there's the inpatient hospital, which is called HCAPS, which is the hospital one. Then there is CGCAPS, which are clinicians in groups, which are really the providers in the ambulatory settings. These surveys have been proven to be valid. They've been developed over the years. The government contracts with a sub-vendor, usually Press Ganey is one of those, to administer the survey. And it's a series of questions which are called domains. So on the inpatient side, there's 8 of them, soon to be 10 of them. So a question is your overall rating of your communication with your physician or your doctor. And then there's 3 sub-questions with that. Then you get outcomes compared to really the national database. The database is made up of all the hospitals. It doesn't matter if you're a community hospital in the suburb or you're a teaching hospital downtown. You're all going to get compared, and your outcomes are weighted, both in terms of what you actually achieved and what you improved upon. It's a very complicated calculation. And then you're compared in percentiles across the whole country. And it's the percentage of patients that gave you the top box. So it's a 10-point scale, many of the questions. So if you get a 7 out of 10, you didn't hit it. You have to have an 8, a 9, or a 10, and what percent that is. So when they talk about your average in the country, you're about 72% of your patients will give you the top rating. That's average. So the bar is really set high. It's appropriate. Giving people feedback on how they do and what the patients say about them, and having that data come back is really important to be able to see whether the process is working and you're improving. It's particularly been shown to be very important for doctors. Who, with the transparency that's coming, where posting of doctors' outcomes are out there, has really moved that, we talk about a shift, has really moved them into focusing on that relationship.
So I'm curious how serious this survey is for the hospitals. And from a medical mutual standpoint, Sue, is it used by the insurance companies at all?
We have a number of different survey mechanisms that are used for different purposes, but not the same.
But do you look at the HCAP scores when negotiating with the hospitals as the payer?
I would say not directly, no.
Okay. Adrienne, has the HCAP scores affected the way the clinic is operating at all?
Sure.
Yeah.
So HCAPS is one dimension, right? It's not a perfect capture of the patient experience. And we often talk about patient experience does not therefore equal patient satisfaction, right? And then we talked about consumers. I heard that word. My patients are the most reluctant consumers I've ever met, right? Nobody is showing up in my MS clinic like, oh my gosh, I'm so excited to see Dr. Boissy. Right? And I say that with a little tongue in cheek, but it's the truth.
Yeah.
People don't want to be consuming our service when it really comes down to it. And so when we talk about HCAPS and you talk about a satisfaction measure, that is one. It's imperfect. And it's one dimension of this multi-dimensional thing called the patient experience. And I think it's really important to keep that at the forefront of our discussion, that that's one way of capturing it. And so what we've done is that we capture not just patient satisfaction data that's required, so HCAPS, but certainly all the outpatient data. We capture patient relations, complaints or grievances. We capture anecdotes, stories, and we compile all of that to create a profile of our clinicians. And we share that information in an unblinded, completely transparent fashion internally, and then as of April this year, we share it externally. So you can go Google me. I hope you have a great time. And it immediately pulls up what patients feel about me and their experience with me. And so HCAPS, as one capture of the patient experience, is absolutely in front of our clinicians on a regular basis to keep it in their forebrain that this is the true north of our organization.
Okay, and this is a score you can Google for all the hospitals and the main campuses. I was going to ask a little bit more about that, but I'm running out of time. And I think it's now time to open it up to patient questions. Before I do that, I do have some announcements to make. So I'm looking over at Dan there, looking at me, and he's probably tweeting, which is about the hashtag I'm about to tell you. Oh, are you? Looking at the scores is interesting. It's not, as we mentioned, as you guys mentioned, the be-all of your experience. Obviously, if you go to a hospital and you like it, you know you like it. But it is interesting to look at the scores and see what the overall ratings are and what the hospitals are working on. So let me do the midway announcements. Today we are enjoying a conversation on patient experience in healthcare featuring Dr. Adrienne Boissy, Chief Experience Officer at the Cleveland Clinic, Catherine Koppelman, Chief Nursing and Patient Experience Officer at University Hospitals, Dr. Sara Laskey, Chief Patient Experience Officer for MetroHealth System, and Sue Tyler, Executive Vice President and Chief Experience Officer at Medical Mutual. We encourage you to organize questions for our speakers now and remind you that your questions should be brief and to the point. If you are joining us, and this isn't flipping, via webcast and would like to tweet a question, please tweet it at the City Club, which is at the City Club. We welcome all of you here and those joining us via the web stream provided by our primary media partner, 90.3 WCPN, WVIZ PBS, 104.9 WCLV, IdeaStream, or one of the many radio stations across the region and country that carry the City Club programs. Television, radio, and web production and distribution is made possible by Cleveland State University and PNC. Be sure to join us this Friday, July 31st, for a conversation on the benefits of Social Security expansion with Nancy J. Altman, co-founder of the Social Security Works. For more information about our upcoming and past forums, please visit us online. We're at cityclub.org. See, you got me. cityclub.org, nonprofit. Okay, thank you very much. I think we're ready for questions now. We've got a couple back here.
Are there groups of patients who might be excluded from your survey process because of their capacity? And if so, are there family or caregiver surveys that are used?
Kathy, do you want to take that?
CMS has rules about exclusions. So on the hospital side, for example, if the individual is transferred to a post-acute facility, they will not get a survey. There's one of the rules. Yes, there are many elderly patients who are, or patients who are incompetent and they can't fill it out. They don't want families to fill it out, but we all feel that that is what happens, that the adult children do fill out, or the parents, of course, fill it out for their children in the pediatric hospitals.
I want to add to that. I actually think that's a huge problem. I think we are missing major patient populations, our illiterate population, for example, our homeless populations, our populations, we here in Cleveland have multilingual populations, and we try to send out surveys to the language that they identify in their medical charts, but just because somebody can speak in a language doesn't necessarily mean that they can also read and write in that language. It is a concern. The HCAHPS survey, the hospital survey, which is the required survey, has to be done either by mail. You can also do it by phone, although you get dinged a little bit when you do that. I'm hoping that in the future there are other ways to survey around that. But we also can survey at point of care for other things. I think that there's a whole range of data that we should be looking at and different ways of finding out data from patients and their experiences. Right now, much of what we do is very reactive. We find out about what's happening after and then plan for the future. We're starting to look at how we can get data in the moment, what's happening now, point of care to you right now, and then maybe make a change. What's most interesting is how can we collect data and look at data that's happening so that we can be proactive about our changes. So I think data around patient experience is really very interesting and exciting, and the place where we should all be looking to go. That's something that's very exciting to me personally. That's a great question.
Okay, I think we had some more questions over on this side of the room.
I need to stand up. Yes, please. Sorry. I am involved with the Alzheimer's and dementia patients population through the Alive Inside Foundation, and unfortunately there seems to be a huge gap in patients getting the diagnosis. There's estimated anywhere from 55 to 65% of patients never get the diagnosis early enough to do them any good. And I think we as people in the healthcare industry need to set the responsibility bar higher for doing that. Can you address that at all?
It's an interesting kind of focus on the Alzheimer's, but it does bring to light the idea of the communication aspect. which I think all the hospitals have been working on, and including Medical Mutual. Could one of you address the idea of how to increase that communication with the patients on the front end, maybe even before they have their procedure or before they come into your facilities or work with you?
Well, first of all, I think you're right? And it's true for many neurologic diseases. I'll take a stab at that, right? Even multiple sclerosis, years to diagnosis for many patients. So it's a real issue. And to sort of segue into your question, there's a number of interesting technologies out there now. So one of the things we're evolving currently is a capture. They're calling it the biopsychosocial model, which essentially would be this beautiful capture pulling on existing data sets that would capture medical pieces, cognitive, behavioral, social pieces, and functional pieces that would represent a patient, and then really pulling into the middle the pieces of the patient that the patient would self-populate that are most important to the patient about their care, right? So to your question, I'm worried I might have Alzheimer's. We should be asking you before you arrive in the clinic, what are you most worried about regarding this issue, right? Or what's your expectation around this visit? Or what do you want your healthcare team to know about you that we don't know, that isn't captured in any of our other beautiful forms? And so could we do that preemptively to get a picture of you that you have created, and so that we're therefore better equipped to address that? There's also technologies that are in pilot stages at the Cleveland Clinic around touching base with the patient beforehand to collate and capture that data and to communicate about expectations before you even arrive, so that when you arrive, your caregiver is ready to take the best care of you that's customized for you and your worries and your fears as a person and human and patient, and as well your caregiver has that in their pocket.
Sue, I'm curious, the idea of communicating with the patients, with the members, is this an aspect that Medical Mutual has been working on as well?
Oh, absolutely. In the industry, we are challenged to keep it simple and speak in language that our customers understand. It's a confusing industry. We have coinsurance, deductibles, we have all these co-pays, we have things that we struggle with within the industry, and to try and put ourselves in the shoes of the customer. One of the investments we made a couple years back is we take probably 10,000 calls a day, and we invested in speech analytics tools that allowed us to capture calls that either show an emotion or have certain phrases or certain words, that we could then listen to those calls, focus listen, and identify opportunities to either improve our process, identify places where we need to do some coaching, some education, where we can change the words that we use to make them more understandable. So some of it is communication, to your point, is a huge opportunity area. It's certainly something that we focused on both in speech, in print, on the web, and in various channels.
Let me just kind of, so you're analyzing the calls coming in and looking for kind of words that you can use to then help go back to your staff and help teach them to
we look
respond.
for where there might be opportunity areas. If somebody's expressing frustration, if somebody's expressing a negative emotion or a positive emotion, if they're using words like, I called you before and, let's pull those. Let's understand, where did we miss the opportunity on the first interaction? Where is our opportunity? Are they calling us because something we sent them or something we communicated to them was confusing, or it was frightening? Looking for those opportunities.
So that warning that the call is being recorded is legitimate. So.
Yes, the call is being recorded for a number of very positive reasons. Coaching, process opportunity.
She's talking about the voice of the customer.
Right.
I think in the communication element, and I'm sure that the other hospitals are doing the same, is that we really put within the scope of patient experience, patient and family engagement. There, the emphasis is working with people and patients to speak for themselves and to challenging of things and questions that they have, but being engaged by caregivers to have joint decision making and partnership. So we actually have developed a number of tools and processes where patients get a booklet that says, to use this on rounds, and these are the things that you might want, phrases that you're telling people are okay to say here. Talk to me in language that I understand. Say that to the doctor. Don't let the doctor leave the room because you're confused, and stop the doctor. And that's the nurse's role to help with that. That's the doctor's role to be different in that.
Right.
So we're really looking at communication from both aspects, the providers as well as the patients and
Right.
families.
It's not just the doctors or the nurses. The patients do need to step up and do some communication.
But they need
too.
to be supported in doing that. They need to know that that's what you want them to do as providers, as clinicians.
Okay. I think I saw some other questions over here. Over here.
Hi, I'm Bernadette from the centers, and we're blessed and fortunate to have all four of you guys leading this community in this area. We know there's a lot of research of staff experience from all levels of the organization has a direct tie-in to the consumer experience and the engagement of staff. Can you each tell us one thing you're the most proud that you've improved of staff experience that we can think of doing back in our own offices?
Can I just follow up on something I said to Adrienne earlier? When I mentioned the doctor communication, that was, I believe, before the clinic started teaching the staff. So if you could answer the question first, I would like you to.
Which question am I answering?
I'm sorry. the one thing you're very proud of.
The best outcomes. So can you give us an example of how you're improving staff experience, what we may be able to bring back to our own companies to improve staff experience?
Okay, so a couple things. One is, for the first time ever, we actually have, everybody keeps talking about how if your staff are engaged, we'll take better care of patients. We don't have a lot of data yet to prove that. And so just recently, for the first time, we had an opportunity to collate our safety data, our engagement data, and our patient satisfaction data. First time we were capable of actually looking at the data here. And there's very strong links, in particular, with staff engagement and safety. In some measures of patient satisfaction, it's true, right? That if your staff are highly engaged, particularly around, I think, nurse responsiveness, and that's really important to continue for us to explore, because patient experience is not this silo over here that has nothing to do with staff engagement and safety, right? Because guess what? If your staff are intimidated by your surgeon, they're not going to speak up that this is a wrong site surgery, right? We heard this at the Empathy and Innovation Summit from the Joint Commission, that the reason that people don't speak up is because they're so intimidated or afraid or in a culture of fear. And that speaks to your question. The second piece of my answer would be, I think that the key to staff engagement, and what I learned after spending 6 years training thousands of staff in communication skills, is that if you take your patient experience data or your quality data and you make it transparent to your staff, and then you say to them, here's your data, it doesn't look so good, I need you to get better. You got that, Tora? If you say that, and you don't have any programs that they can then take and run with, it is the definition in my mind of futility, right? Because here you are telling people who are trying as hard as they can, who do care at their core, and you're telling them what they're doing isn't good enough. And that's not the culture we want to be creating. The culture we want to create is a dialogue around, I know you're working really hard out there. I know you personally. I know you care about your patients. Tell me what's going on. And giving a peek at this, tell me how you think this compares. And what can I do to help you, given your current state? So in my mind, the key to staff engagement is not coming at them in a organizational-centric way and telling them how, as the chief experience officer, I think they need to do things. It's meeting them on the ground level and saying, help me understand what your world looks like. Help me understand the challenges. That is relationship-centered care in action. Help me understand what your world looks like. Help me understand where you're feeling really engaged and where you're not feeling engaged. And given that we all want patients at the forefront, how can we get there, given what we're working with? And so it's treating our people with the very same respect and relationship-centeredness that we're promoting so vigorously with patients. That, to me, is absolutely critical.
I see Kathy shaking her head, so I'm going to let her jump in.
No, I totally agree with Adrienne. I think that patient-centeredness and the principles of that apply to how teams work together. So I think in terms of engagement, we need more research on the relationship, which she pointed out, to the outcomes for patient experience, but intuitively and philosophically, I believe in it. I think that there's things that we do at UH that I'm very proud of for our staff. There are risks as clinicians working in these environments, and it's very depleting emotionally. And how much more do you have to give to others? We do Schwartz Rounds, which is a national program which brings clinicians together to talk about their experiences and the toll it takes on them in the giving of the compassion to others so that they feel heard and understood. I think those kinds of things are really, really important. I think we did a panel discussion just a couple weeks ago with a program with physicians, and we had physicians talk about this very thing. I think we don't spend enough time in support of the people who are providing this care and the recognition of what it takes and how we help replenish that for them.
Sarah, did you want to address this? You're smiling slightly over there.
I think it's great that this is such a collaborative, we were mentioning this earlier before we started, it's a very collaborative industry. We share a lot of ideas and we really have so much agreement. So we're all going to just be nodding. Yes, that's really, I agree. To give you two specific things that we've done at Metro that I think have been successful, I hope they've been successful, that we've done with our HR department. One is we created a program to reward the people who have really gone above and beyond representing our values. So we have a specific set of values that we call our STAR IQ values. I won't go into all the specifics of what STAR IQ stands for, but we came up with a STAR IQ Genius Award, and that rewards above and beyond values. And then we started thinking, but wow, we have a lot of, Kathy explained those the top box. We have a lot of people who just come into work every day and they do great stuff. And I'm sure all of you work with people that you know you can count on every day. Those people who just, they go out of their way, oh yeah, I'll do that for you, don't worry about it, or that was great, thank you so much. Those are the people you can count on. And so we came up with this pay it forward. So we are distributing to every single person in the organization. I'm looking for my name tag, I don't have it on, but I already gave mine away. We're giving to everyone in the organization a little pin. It's a Metro pin. And when you see somebody who's doing something just kind of great, you take off your pin and you give it to them and you acknowledge what they're doing and you say, thanks, I'm paying this forward. And the point is not to hoard pins. The point is, well, we'll see if that happens, but the point is not to have lots of pins. The point is to give it away. So I saw this really lovely OBGYN nurse, and she was talking to this very young pregnant woman. I mean, she looked like I was worried I should stand there just in case something was going to happen. But very young pregnant couple, clearly like walking around kind of waiting for something to happen. And she was just by the cafeteria calming them down, saying, you're going to be fine. This is what you should expect. Just making them feel so much better. This is the elevator you need to go to. And I just thought, this is the caring that I want to see at my hospital. This is the caring that I do see at my hospital. And I took my pen off and I said, thank you. And she didn't even know what the program was about yet, but thank you for doing this. When you see somebody doing something great, pay it forward.
And then when you saw her again, she had 5 pins on
She
her.
did. She was like loaded down. But hey, you know what? If she is and she keeps doing it, then she becomes a Star IQ genius, and boom, we're good.
So I think we heard a little bit about your staff successes with analyzing the phone calls, but there must be some other examples.
You know, I was just thinking we were talking about some of the ways to raise staff awareness. These are very tactical, but you know, some of the things that we've done that I think have been very effective is when our new employees start work on their first day of work, I meet with them and we talk about the customer experience and our service philosophy, and that we are in the business of peace of mind. It doesn't matter what their job is. I think that's effective. Something we did when you talked about the pins, and some of my teams here that was involved in this, for several years we've been hijacking the week in October that's traditionally known as Customer Service Week. We rebranded it, we hijacked it, and we call it Customer Experience Week. We engage every department, every employee in the company, and we use it for a lot of excuses to recognize those examples of customer experience that we want other people to emulate. We give opportunities for individual employees to recognize other employees when they see behaviors that they want to model, have opportunities for our CEO and other executives to write blog entries about it, to recognize employees, to say what it means to them. So I think we look for every opportunity. They may be tactical and they may be small, but it's just that raising that awareness of the strategic importance. It's reinforcing, it's rewarding the behaviors that you want to see, and it's contagious, but it's cultural. It takes time. Cultures move slowly, but as we do each of these things, you see us progressing in our journey.
I'm beginning to feel warm and fuzzy all over. Somebody ask a question that can. You've had your hand up before. Let's, if we can get to. Sorry.
Hi, good afternoon. Great discussion. I'm Dr. Giselle Green. I'm Chief Medical Officer of the Sisters of Charity Health System, and that includes St. Vincent Charity Medical Center in downtown Cleveland, Mercy Medical Center in Canton, and we have a 50% ownership in St. John Medical Center in Westlake. We have had the similar experience with the patient experience of care and caregivers. Our caregivers care, including our doctors. The issue is, how do you demonstrate that caring? And everyone does not have those skills, and indeed, as you all have emphasized, those skills do need to be conveyed and taught, and opportunities put in front of people to learn them. My question is about physicians, because it seems to me that starting at the level of the hospital is a little late in physician education. And I'm wondering, do you envision a future where at the medical school level we will begin to teach patient-centered, empathetic care in a more formal manner, so that just like you learn pathophysiology, that you learn what the human values are in medicine as well?
I think any of you are qualified to answer this. You have residents in your
we
hospitals
do.
every day.
I think it's going to trickle down. So we are currently working with our residents. We're producing programming for our residents. They have a professionalism requirement, and I think this fits in with that very well. I think you have to start with current physicians, because if you have residents or medical students that come out, and many of them do come out very touchy-feely, as we called it at CASE, and they hit the roadblock of mentors and older physicians who are suddenly giving them an example that is not an example that we want them to emulate, then you have a problem. So I think we have to start from current physicians, really embed this, move it down so that residents are learning from physicians who are doing the right thing, residents who are then teaching medical students, and then embed it into medical education so that it is a through line all the way through, so that everybody as they go through is seeing the same thing occurring in the same fashion.
So if I could piggyback a little bit, really great question. And we had sort of this strategic moment where we had to decide, well, if we're going to start, if we're going to start training or facilitating communication skills with our physicians, who do you start with? What groups? Do you start with those that are scoring lowest? You know, how do you score? There really is a lot of strategy that goes into these programmatic decisions. And for us, you know, if you look at the data about empathy, right? Empathy is very high. It peaks when people are in medical school. We squash it out during residency, right? We don't reinforce it, and the skills aren't modeled to them. And then you release them as staff physicians, and then you're wondering why we're having this conversation about, I mean, it's almost ironic. We have bred a system that does not inculcate or reinforce the values that we're so desperately seeking. And so it's not the physician, right? It's not the staff physician's fault that we've created that environment. And so in my mind, people learn the art of medicine through modeling, right? I mean, you can teach humanities in medical school, but then if you squash it out while they're running around on the floors, you have modeled that. This is why there's such discussion about the hidden curriculum, because what they're really learning is that you don't really mean it. And so we chose to start with staff physicians. Because they are modeling every single day the skill of communication. And they are the ones right now who are ultimately responsible for their scores. There's very high expectations placed on them, and we're being transparent about what patients are saying about them. The expectations of the staff physician is very high. We absolutely need to be equipping them with programs that help them succeed in this environment. And we also had pushback and challenges. They said, well, it's not really me, it's the residents, or, you know, and the answer is no. The buck stops with you. We're starting with you. And if you're a very talented staff physician who's effective at communicating, we'd love to all learn from you.
And we're going to have to leave it with that, because I'm getting the signal for the time. It's been a wonderful discussion today. Thank you so much for asking the great questions that were asked. Thank you to our panelists for joining us. I think we're learning that, this discussion is going to continue outside these walls. Thank you for being here today, everybody. Can I do this?